to start the event. It gives me great pleasure to have Professor Dr. S. Natarajan here with us, who is an esteemed ophthalmologist with over 35 years of experience. He has performed over 60,000 exclusive vitreous and retinal surgeries, and he has trained more than 68 vitreoretinal surgeons across the globe and has presented more than 1,500 invited guest lectures globally. He is considered an authority in vitreoretinal surgery in the world and is keenly involved in academics and research for the prevention of blindness. He is invited to teach as well as speak in prestigious universities across the globe, and his work has been published in hundreds of international journals. He has been awarded one of the highest civilian awards by India, by the President of India, the Padma Shri. And he is also the president of all ocular trauma societies in the world and a pioneer in vitreoretinal surgery in India. He is no stranger to us, as he has been closely associated with us a few years ago when he collaborated and did difficult surgeries for deserving patients at our hospital.
First slide.
Can I have the first slide, please?
Remote. You can go, I think, go up, I think, no? Backwards. Yes.
Padma Shri Professor Dr. S. Natarajan is also the Chief Clinical Services of Aditya Jodh Eye Hospital in Mumbai. He is also the Chief of Vitreoretinal Services of the Dr. Agarwal's group of eye hospitals in India. He is the President of the Teleophthalmology Society of India, the President of Asia Pacific Ocular Trauma Society, and the Treasurer of the International Council of Ophthalmology, President of the Shankar Nethralaya Alumni, and President of the Eye Cancer Society of India. It gives me great pleasure to invite the esteemed Professor Dr. S. Natarajan to give his speech now. Thank you.
Thank you, Dr. Gayatri and Dr. Paul Singh. And I'm happy to be here again. As Dr. Gayatri said, I'm not a new face here. So why the heads-up is so important? 3D visualization system allows retinal surgeons to operate looking at high-definition 3D screen. It's like watching the screen and operating, and instead of bending their necks to look through the eyepiece of a microscope. Traditional vitrectomy surgeries range from 30 minutes to 3 hours in length to complete, and this microscope-free design is engineered to improve surgeon's posture and may reduce fatigue. But my word of caution to every surgeon is to do good exercise so that you make the antagonist and protagonist muscles of the both abdomen and back to be strong, even though that should not be the only reason for using heads-up surgery. And this is what Dr. Klaus Heckert introduced, but I'm happy I do only heads-up surgery now. The first concern for a veterinary surgeon is to maintain a comfortable and stable position that allows to carry the surgical procedure safely. And this was the one which is published in 2018. The first one is the Ingenuity 3D visualization system, which came into the market, and that's made by the Alcon. And the 3D visualization system was developed in collaboration with TrueVision, 3D Surgical, a California-based leader in digital 3D visualization and guidance for microsurgery. Consists of a 3D stereoscopic high-definition digital video camera and workstation to provide magnified stereoscopic images of objects during microsurgery. And it acts as an adjunct to the surgical microscope during surgery, displaying real-time images or images from recordings. And it's comprised of several elements: the dynamic range HDR camera, increased magnification while maintaining a wide field view, highlighting ocular structures and tissue layers, which is imperative to visualize the back of the eye. And this is what I enjoy doing it, because whatever you are seeing inside the eyepiece, it looks so small, and when you see it, you're like you're seeing a world of difference. But the problem is the cost. The high quality precision start to finish, the high level of precision with the Ingenuity removes the need to refocus without losing any detail, up to 5x extended depth of focus, 48% increased magnification, and 42% increased depth of resolution. Customized digital image. And I'm happy to say that Upper Sami from India has made an Indian-made True Globe 3D video microscope. Still, the quality is not same as Alcon, but nevertheless, I think this has a full HD and 4K resolution, and it has a stable reflex. There's some echoing happening, and so they have the complete 3D setup with 3D digital recording, image capture in 3D. So they have a toric max overlay guided alignment for toric IOL positioning, a 3D squint max overlay marking scale for squint surgeries, patient data software built in, special software for recorded surgery playback, visualization 3D, high grade passive 3D goggles, spectacle clip on the 3D goggles, and it's like similar to the ones available now, and foot switch for recording a start and stop and image capture, ergonomically designed motorized tiltable stand for 3D monitor, an all-time hybrid setup binocular, 3D viewing simultaneously enabled. And this is for the entry segment, the technical specification, and that's for the posterior segment with the re-inverter, variable aperture, and optional accessories is again a medical monitor, which is what is the most important because image you are seeing. And recently it looks like a science fiction. This is a company from again US. They're made by two engineers, the brothers. The company is called Ocutrex, and actually they are two brothers. Their parents had, I think, macular degeneration and the vision was poor. So they were developing something for image enhancement and landed up in making this microscope. And it's amazing contribution, still not available for a trial also. So they call it OR BOT 4900 3D surgical visualization data. They have this Camtrex digital microscope which captures live surgery feed, which is displayed to 3 visualization sources depending on surgeon's preference. And I also have the OR lens. It's like a headset, which I didn't like it because it's like playing the AR or the VR games in the headset. And the other is a stereo lens. It's a 8K 3D glasses-free monitor. So you can see the 3D, but you need glasses, which is I tried this in the last year Frankfurt at a meeting which Dr. Classic conducted, and even I have given an input. I hope they will bring it for a clinical trial to my operation theatre. But this Camtrex microscope captures digital surgery feed and displays the video image to the display options. And you can see the comparison of optical zoom in Ocutrex is 20 times, and Alcon has 16 to 20 times, Leica 16, and Zeiss has 16 to 20. But the digital zoom, it has 360, and it's not available in any of the other things. And Micron's result is 3.5, which is again not available in the other 3 companies, and 3D is yes for 3 of them. And our color spectrum is 69 in the Ocutrex, and resolution is 50, where the rest of them are 4.2, and Zeiss has got 8.4. And you can see this is again the OR lens, the resolution, the horizon, and the HoloLens. And you can see this is actually the OR what displays surgery video feed from Camtrex microscope to stereo lens monitor, enabling user to see in 3D without needing to wear a 3D glass. I tried this where you can see how you can use it without a 3D glass, which is something amazing because for a person like me, a surgeon like me who don't need glasses, you don't have to wear any glass frame on your frame. And you can see the Alcon has the 20x, and the Ocutrex has 120x, and only Ocutrex has 240 digital magnification. It's amazing. This is actually the seeds of in the flower which has been magnified, and you can see all the 3 where you don't lose the resolution. And they also have a Scopetrex, which is a 4K laparoscopic swivel camera, and which also can be connected, can view live surgery feed from Scopetrex to either OR lens headset or a stereo lens 3D monitor. And the other one, which is made by Bosch & Lomb and Heidelberg, which is now commercially available. I think they have got the FDA approval and the CE marking in Europe. So this is a new dimension, fully digital visualization called the C-Luma. And here you see they made a C-loop. If you have seen the Alcon or the sites, which I will come shortly, where you have to see on the side. You have the microscope binoculars in the center, and then here the binoculars have been removed, and you can see the so you can see the so you can see there's a C gap here. That's why it's called. They made it a C as C, but it's actually a C loop made, and there is no binoculars, so you see directly. So this is the perfect thing where you don't have to turn the neck one side and see, and this can be simultaneously transmitted to about 8 places without losing the clarity. And again, there is a picture, a brighter future, where the world's first digital binoculars, where this is what they are showing, and then you can see the fine thing which can be magnified. You can have the same size of the screen in the front, and looks like that you're close to the television monitor and operating, and you can see this is how the visualization looks. And then you can also mark the for a capsule of access, and you can use it as a teaching, because you have a digital screen which is a smart screen, and you can mark the markings and teach fellows more better. But unfortunately, it's going to be something 5 times the cost of the existing microscope. These are the features of the C-Luma, and this is what I tried in the wet lab. This is the, and you can see this is the C-loop through which you can see. Bionic eye, and I'm going to use the bionic bottom of microscope. The idea is where a 3D glass, and then you can use this beautiful view. And the video is taken using a mobile, so you don't have the 3D effect. So you watch the screen in the center space, so that the advantage of over the Zeiss and Alcon is you see it directly, but if the cost is very exorbitant. But nevertheless, I think technology, that's what I want to show, the advantage of using the 3D. Again, you see, so between this gap in the C loop, you'll be able to see the screen and operate. And at the same time, as I said, we can have a 8K transmission to live surgery and many monitors, so that whoever wants to record and then also teach or using the smart screen. So this is the other one, which is a future of optical inspection, which cannot be used in the operation theatre, and that's the called the deep reality viewer, which they use for watch magnification and seeing the parts of the watch or any mechanical instrument, which is the first world's first and only digital stereo inspection system, which creates full 3D HD image that appear to float in front of your eye. You don't need any special glasses or goggles, and there are no unpleasant side effects. And you just sit back and view high definition 3D images with outstanding depth perception as easily as a real life. And actually I made a 3D chair where, a regular chair with the armrest and the numerical rest, but you can sit back and operate, which I never could imagine doing the regular method, because you're all the time have to go to the eyepiece. Here you don't have eyepiece, you have to sit back and keep operating. So it's like playing a video game. So one day the robotic surgery can happen like that. I don't know when it will happen, it will happen. I have a video clipping of robotic also, which I will be showing in the next talk. It is a remarkable invention which is already revolutionizing the way organizations view, capture and share 3D images of the samples they are studying. And it has an outstanding ease of use. There's a supreme comfort and an exceptional ease of use where the DRV 70 has minimal setup, and it's versatile and convenient, and it also has a short base. As you see here, the examiner does not need glasses. You can sit and you can operate. You can do using the wet lab or in the dry lab, and then so it's a powerful combination, a real-time collaboration on a global scale. And you can see this is the photograph where I use this system, where you can see the screen directly, but it's a 3D view, which is something. And here we have the Starbucks, who was the president of Boarding Club, Dr. Yannick Lemaire from Rothschild Hospital in Paris, and that's from the Moorfields Hospital, the one who done the maximum surgeries on second side artificial retina, Lyndon Cruz in Moorfields, and also now he's doing gene therapy. So you can see So you can see that you can directly see through the screen, and you also have a 2D screen on the side for just for others. You can do the vitrectomy. Actually, you're using a body device. You can inject the yolk and do a vitrectomy using that. So the idea is to again say you can keep your back by relaxing and operating. So you can see this is the close-up where you see the 3D viewing, and my view is through the center where you have the 3D view without the glasses, and that's the advantage of using the system. But as of today, it can be used only for a wet lab and dry lab, and not for surgery. But anyway, one day it will happen because it's an amazing system. So the benefits, and with the digital 3D VR surgery, this is where there will be a tussle between the surgeon and the administration, because the cost is a problem, but still it has improved ergonomics. Posture at the microscope for several hours leads to musculoskeletal fatigue and pain. That's why I said you should do exercise apart from the newer equipments. And with the surgical field displayed on the unit placed at a convenient position, the surgeon can maintain an ergonomically neutral position, and this reduces musculoskeletal fatigue for the surgeon. But it's not a replacement for exercise. You should be strong with your back, but you're going to be a vitreoretinal surgeon or any eye surgery too. And this is the Zeiss also claims as the first digital microscope. I don't have any financial interest, but I use Zeiss now. It's a new era of visualization in ophthalmic surgery, delivery by the first digital microscope. And advantages, particularly in the posterior segment, it's best combined with the chandelier illumination. I will be able to show gradual transition from binocular to screen, excellent stereoscopic perception, large screen, high resolution, crisp viewing. That's what I enjoy now, because I also have a OLED at home for watching movies, and I think the same feeling I get when I'm operating the 3D. And I do everything, right from scleral buckling to suture removal, and then even injections on the 3D. And I think it's fascinating. And plus the entire operation theatre staff, whether anesthetists, nurses, students, doctors can watch what you're doing. And some of my friends in US tell me they don't want to buy 3D because whatever they do, everybody can see. But I said the idea is to teach. And if you make a problem, I think you have to learn to solve it. It doesn't mean you have to cover it up. And the clear distinction of membranes while dissecting, you can imagine the 2 layers of a cloth, you can see it so big in a screen. And you can, so that the trauma to the patient is less and better visualization of stained vitreous. That's my theatre setup with a 3D in the Aditya Youth in Mumbai. And then we have so the other benefits are dynamic contrast, can improve brightness. Yeah, so I use only 5 or 6 in the illumination for endo illumination or a transfer or a channel illumination. Even routinely we may have used more than 30% and all. Here, the least illumination you'll be able to see well and apply dynamic digital filters to enhance visualization. Image quality often better with traditional microscope, digitally magnified, inverted image possible. So without inverter also it can work. And as I said, significantly low illumination used translates to lower phototoxicity for patient. That means finally the patient will benefit. It may be difficult to measure what's the benefit of using the 3D over. So we have done a study which we just got published, which I just mentioned now. It's a real-time responsiveness. There is a latency for a few seconds, but I think every surgeon who's using the 3D will get used to it. You don't have to think. It's like using the indirect ophthalmoscope when you're switching from direct to indirect. But I think nowadays, whichever ophthalmologists are learning, they directly learn. You don't have to think about it. So same thing you can do with 3D. And vitreoretinal surgical steps are often slow and delicate, hence a small latency, and it is not significantly seen by the surgeon. But I think even a cataract surgeon and a glaucoma, anybody can use this, which is what I feel good for eye surgery. And good adaptability, switching to digital 3D can be a challenge with the learning curve for some surgeons, but for me, I use any instrument because my hands and legs speak to the machine, and I adapt to any machine, and without knowing the language of the staff all over the world, I operate. But I think I do 3D in Zeiss in my OT. Last year when I went and did surgery in Mexico, I did with the Alcon, but I think I didn't have any problem. So one is you have to know about every instrument, what you're going to use. And how a surgeon have not reported any difficulty and the learning technique. And it's an advanced teaching tool. Displays of surgical field are seen by the surgeon for the entire OT. So more than one person can be trained simultaneously. Tissues or area can be pointed out on a screen and again instructing with left, right, up, down direction. And simultaneous heads up view by instructor and trainee improves the coordination during surgery. So all can wear the 3D and watch the surgery as seen here. And this is my OT, and so that's my nurse who was there with me more than high school. Yeah. So you can see that all the surgeon and the fellow and the nurse wears the 3D glass, and you can watch in the big screen. And here you have to see from the side because the binoculars are here. The only advantage between the Alcon and Zeiss is Zeiss has a binocular. Some surgeons, somehow I don't know why, they do a 3D video recording, but they use the binocular, and I never use the binocular, which is here. This is this one, which we only can switch over, and which is what, and that's my nurse who's working with me more than 35 years, so I don't have to speak anything about the surgery. Even the surgical plan, she knows what I have in my mind, even though my fellows writes it down, and everything we can all can see that. So there's a separate monitor on the behind where they can do a photograph and do video setting. So I have some interesting cases to show. This is a proliferative retinopathy with a traction detachment with a preoperative vision of 2/60, and then I used 25 gauge 3-port pulse spironectomy. I do this bevel entry so that I don't have to suture at all. Usually, if you have a bevel entry properly, no need for suturing. You can see the anterior posterior traction is relieved, and tangent retraction also is relieved. And I use the mode called proportional mode of the vitrectomy machine, where you can flush the fluid between the membrane and the retina. Only thing, it may take time. You can either do the forceps and scissors using a channel illumination, or you can use this. I'm now pushing the fluid between the membrane and the retina, so the cleavage is created, and with the water force, so it acts like a laser blade, but without any mechanical blade there. But then you can trim the membranes and then totally remove all the membrane, and then do a pan-retinal photocoagulation. So 3D visualization, the entire OT can watch, and then you also can see everything magnified, and you can identify the membrane and the retina, and it's a little patient technique to be done, but I think it is rewarding, because finally patient's eye and the visual recovery is the most important you need. So the patient had a 6/9 post-operative visual acuity. The patient had a disc pallor, but all membranes have been totally removed with a good pan-retinal photocoagulation, except the disc and macula. And then this is again a technique which I described for the pellet injury. So you see the 3-port plasma vitrectomy done, and this is the pellet which is seen, and then we complete the vitrectomy, but the pellet is not removed from the vitreous hemorrhage. So, and then we make a separate incision so that we can grasp the pellet from within the vitreous hemorrhage without the pellet gets removed and falls on the surface of the retina, so that sometimes it can produce actinic trauma. So I devised this technique where so that you don't have to make the pellet fall on the surface of the retina. So make a 11:1 scleral incision and use the 4-prong forceps, which was made by myself and Dr. Manish Papai and Mahesh Shanmugam, which were published, where you grasp the irregular foreign body like this and remove it through the sclerotomy, and then suture the sclerotomy. And this is the same. You can see that the corneal suture done, and it's an aphakic eye. You can make a small incision and partly vitrectomy done, and then you can see the 4-prong forceps designed by us and made by Epsilon. Again, I don't have any financial interest. You can grasp the foreign body like this and bring it out through the sclerotomy, which is 3.5 millimeter from the limbus, and then that's how it's placed, and close the scleral wound, and then connectiva, and then proceed with the 3-port plasma vitrectomy. This is a little modification. The idea is to make sure that you don't use the same vitrectomy, the 3-port or one of the ports for enlarging and removing, and then complete the vitrectomy surgery after removing the pellet. Here you are removing the charred vitreous because of the velocity and the heat generated. Sometimes the vitreous is charred, and then there is actually a localized retinal detachment inferiorly, which I will segregate by using the endolaser and clear the vitreous base excision. And this is the aphakic eye. You can see the exit wound is next to the optic disc, and so I do a laser around it, like a coloboma choroid, and then filter the fluid exchange. And 3 months later, the local surgeon or a well-experienced surgeon. This was done in Srinagar in Kashmir in 2016, while there was an unrest, and there was almost 10,000 people had a pellet injury. 1,000 of them had eye injuries, and we have published the largest series in the world with the 777. You can see that's the exit wound, and I have done the laser. So this sort of patients, aphakic correction, had a 6/6/9 vision, and we can put a second over 3 months later, and the patient can have vision. But 80% of them got only counting finger vision, because the injury was either optic disc or on the macula or on the center of cornea. So I think if the disc and macula are spared, they can have an excellent vision, and that's why I'm using the fluid exchange. And wherever there is a break, we could run the endolaser, and retina was attached throughout. And this is a twin light for a vitreoretinal surgery, where we use this is not available now, made by DOT, designed by Claes Eckhardt. It is a stiletto with a double entry, And now what I do is I make an entry like this, but I use two single chandelier illumination which is available. Paul Torben may describe that. Here you put the two and then use the forceps and scissors and do the biomanual, which is surgery. So again, when you do it in the big screen, you're all the time the vision is, surgeon's vision is for the distant, and then you can see you grasp the membrane and then dissect the membrane. And this way, our aim is to have 0% iatrogenic rectal breaks. And in the 80s, I think they reported 18 to 20% having iatrogenic rectal breaks, and now we aim at almost 0% iatrogenic breaks while doing surgery. So the advantage of 3D is you can see the big screen and magnify, and then you can identify the attachment between the membrane and the retina and dissect. And you can remove the entire membrane. It may take long hours. That's why you have to have the back strong. So this has been accepted for publication, comparison of cognitive workload and surgical outcomes between a 3D and conventional microscope macular surgery. So in this study, comparing the 3D and conventional microscope visualization system for macular hole surgery, we found that the 3D technology reduces the surgeon's cognitive workload significantly. Additionally, our study demonstrates that the type of view system has no bearing on the overall surgical time, ILM peeling time, surgical complication, visual acuity results, or macular hole closure rate. So I think it's a mixture of visualization, magnification, and your technique to solve the problem. And in this study, the was done by Dr. Aditya Kelkar, Dr. Monica Polisetti, and Dr. Akshay Kothari. It's a joint work between Aditya Group and National Institute of Ophthalmology, Pune. And this is my 3 generations working for ophthalmology. And my inspiration is Swami Vivekananda, arise, awake, and stop not till the goal is reached. And I learned from Swami Chinmayananda, you have to keep the goalpost ahead, keep on pushing so that you always work with outstretched hands. Thank you. So you can ask some questions, then I'll go to the second talk. That's what cost is exorbitant, and I think in Indian rupees it's about 3 crores. I think if you add intraoperative OCT, again adds to almost another crore. And this Bausch & Lomb is maybe more, I think, 5 times more than this. So cost is not really correlating with the return on investment for a hospital. So that's why I took donation and I bought that from the foundation. So whatever patients do free, we do it free with that. And paying patients, we charge, and then the money goes to the foundation. Because it belongs to the foundation, and then the corporate hospital, if it we use per patient, we pay the usage of the machine. So that works better. So for charity, you can ask for a donation instead of asking the hospital to buy, because it's not going to be cost effective at all. Because most patient would like to pay just for this little benefit. Definitely there's a little benefit, but a patient can't understand that, no? Whether you do with a regular microscope or a 3D, the surgical results are mostly 95% depends on the surgeon's caliber and not the 3D or visualization. Yes, Doctor.
Yeah, it's not a question, just more of a comment on what Dr. said. I think we doctors must start to learn to utilize such things in groups. For example, you can have one machine here, your system, and all surgeons close by recording all they should be able to use that machine. So that is optimally utilized and more people can benefit with reduction in cost.
Yeah, I agree. No, definitely. It's like the general hospital with some specialty, and surgeons can pay for the operating room and operating microscope separate, which is possible. There are multiple centers in India happening now, but it's not popular. I don't know why, because somehow they have an ego, I want to own everything, which is a problem. But you can go, and I think it's working in few nursing homes or small hospitals in Bombay and in Bangalore, everywhere. But I think definitely it's a good idea. But in your case, it's somebody wants to ask a question. Okay. No, I think this should be possible as a donation from some philanthropist to the Toulouse, because it's an NGO, I think, where you do for charity. So, and then you can. Yes, yes. And even the paid patients can pay for it. We should tell the difference. We should not underestimate our own. Because the people want luxury, they go to 7-star and 5-star resorts and hotels. And when they get paid there, why not for ICL? And people who cannot afford, I'm sure they are all doing free or very nominal, which all of us do. Anybody from the OT wants to ask some question or comments? I think you had, Paul Singh said you had the microscope for demonstration some time back. Was it useful? No comments?